can see it and we can begin.
Yeah. So,
Thank you.
Thank you. Thank you, Caroline. So, we'll try to discuss today a really interesting topic, which is the endometrial receptivity and what can we do in order to improve our rates of success in the IVF treatments. So first of all, we'll go through all those different aspects. First of all, the definition of the endometrium and the importance it has. Also, what is called the endometrial receptivity and microbiome, different tests that can be offered to our patients in order to increase the results of implantation. We'll also discuss about the uterine factor, which is something also important to consider. And also we'll speak about what is defined as recurrent implantation failure, and also the strategies that we might have to try to increase the results. So talking about the definition of endometrium, it's important to know what is defined as endometrium. So I guess that many people might know that endometrium is defined as the innermost layer of the uterus where the embryo implants and where the fetus develops during the pregnancy. So the endometrium changes every month, and depending on the moment of the cycle, it has different aspects. So we know that the estrogens that we produce in the first part of the menstrual cycle will have an effect in terms of increasing the thickness of that endometrium. However, the progesterone, which is known to be the hormone from the second part of the cycle, will change the aspect of the endometrium and will make it more receptive for implantation. So both hormones can be used, and actually they are used for the preparation of the endometrium when we want to transfer an embryo that has been normally frozen before. So the endometrium, it's important, as we were saying before, because it's the place where the embryo will implant, and it's the place where the fetus will develop during the pregnancy. So we need to have a good endometrial thickness. First of all, we always try to have a triple line aspect, so 3 lines that are quite visible when we do the ultrasound, because it's known that that triple line aspect will increase the chance of implantation. So it's also important to have a good endometrial thickness. So we consider that a normal thickness would be over 7 millimeters. I would say between 7 and 12 millimeters would be quite acceptable to move forward to a potential embryo transfer. So in order to achieve that good endometrium, sometimes we can achieve that good endometrium just in a natural cycle, right? So with no using, there's no need of using estradiol to make the endometrium grow. As we know that when a patient has regular menstruations, it's possible to produce natural estradiol, and that estradiol will have an effect on the endometrium and will also make that endometrium grow. So in the end, a natural cycle would be a good option to have that good endometrium. Of course, not for all patients, just for patients that are menstruating regularly. Of course, as we were saying before, when using estradiol and afterwards progesterone, the endometrium are also supposed to have that good aspect and thickness for that potential embryo transfer. And we always see it depending, of course, on the IVF round we are doing. It's possible also to make the endometrium grow using the gonadotropins we use for the stimulation of the ovaries. However, some patients might need different therapies to try to improve the aspect and also the thickness of the endometrium. So those therapies, and we'll speak about that in a while, can be related to using aspirin, also the sildenafil, or many other strategies with the idea of improving the results in terms of thickness of the endometrium and also aspect of that endometrium. So why is the receptivity of the endometrium so important? So we know that the window of implantation is defined as the period of time when the endometrium has the best conditions for the embryo implantation and for letting a pregnancy happen. So that window of implantation depends on the effect of some hormones such as estradiol and progesterone, and it might vary between women. So we know that between 25 to 30% of patients might have that window of implantation displaced from the normal moment of implantation. So we know that, as we said, around 70 to 75% of patients might have that window of implantation 5 days after having a study with progesterone. That's the reason why if we are transferring blastocyst embryos, we wait for 5 days using progesterone to do the embryo transfer, because it's quite likely that the window of implantation will be located in that time. However, as we were saying before, around 30% of patients might have the window of implantation slightly earlier or later. And it means that those patients might need more hours of progesterone, which is the hormone which is in charge of changing that receptivity of the endometrium, or might need less hours of progesterone. So I guess that many people will know that that window of implantation can be studied with different tests, and we can have like a personalized moment to do the embryo transfer for many patients. And of course, we can also know exactly when the embryo transfer has to take place, depending on the information we get from that endometrial test. Apart from that, receptivity of the endometrium, which is important to consider, but it's also controversial. We'll discuss about that in a while. So we know that there is something that can also be studied before an embryo transfer happens, or also under certain circumstances, such as repeated failure of implantation or biochemical pregnancies or even miscarriages, which is called the microbiome of endometrium and the potential chronic endometritis. So the microbiome is the the environment of microorganisms that are located in the endometrium. So we know that there should be like a good balance between the bacteria we have in the endometrium to allow us to improve the results in terms of implantation, and also in natural pregnancy also happens. So sometimes we might find some pathogenic deviations in the dominant microbiome in a patient, and it might play a role in terms of implantation, and it could be related to infertility. So as happened with the endometrial test more related to the receptivity of the endometrium, it's also possible to check that microbiome, and it's also important to check if there is any kind of chronic infection, so that chronic endometritis that might also play a role. So as you might see here, there are like different species that are found in the endometrium. So most of them should be the majority of the microbiome and also the bacteria that we find in the endometrium should be lactobacillus. So those lactobacillus are supposed to be found in our endometrium, but sometimes we might also diagnose that there could be an infection, and it can also be like some kind of disbalance in the number of, let's say, lactobacillus we have in the endometrium. So as we were saying before, there are like some tests that are designed to give us information in that way. The first one, which is called, in this case, we use the test called time, is designed to give us an assessment in terms of the receptivity of the endometrium. So that test, as we were saying in advance, is designed to give us information in terms of the receptivity, let's say the moment when the endometrium is more receptive to the implantation, to decide when would be the moment when the embryo transfer has to take place. So this test is not ideal for everybody. So we normally recommend that kind of test that, as I said, could be controversial, because there has been quite some research saying that could be useful, but of course, as I said, it doesn't, it's not valid and it's not useful for everybody. So in our opinion, it's important to select the cases where that test can be, as we were saying, useful. So the idea is that that test can be offered to patients that, as we were saying, might have like a failure of implantation when we have transferred cellular embryos with no success. So it could be quite useful. And apart from that, it can also be useful for patients with biochemical pregnancies, and also when there is just one embryo available. Let's say we do, for instance, an IVF treatment in which we just get one embryo to be transferred, normally after doing the pre-implantation genetic screening. So when there is just one embryo, sometimes we want to maximize the options of doing the embryo transfer in the best moment for the patient. So that's the case. Doing that window of implantation test can help us in personalizing the embryo transfer in the best moment for that patient. Apart from that, as we were saying before, this test is supposed to increase the chances of implantation, but as I said, it doesn't apply to all patients. And there were some research saying that maybe it wasn't so useful. As we said, in our opinion here in Clínica Tambre, we don't use that test for everybody. So we try to select the patients that could have or could get a benefit with that test. Okay. And regarding the other part of the test, which is called META, that test is designed to diagnose potential chronic endometritis and also can diagnose how the microbiome of the endometrium is. So, as we were saying before, it can also be indicated in patients with repeating miscarriages, as we know that the chronic infections can also be a reason to have biochemical pregnancies and also repeated miscarriages. And patients with recurrent episodes of vaginosis, like infection in the vagina, can also have an increased risk of also having chronic endometritis. So, depending on the result we get in both tests, we can adapt the upcoming embryo transfer. For instance, when the window of implantation is not in the correct place, as we were saying before, it's possible to adapt the time to start with the progesterone in order to get the endometrial receptivity in the best conditions possible. So if the endometrium needs, let's say, one more day of progesterone, the progesterone intake will be started slightly earlier to the embryo transfer some hours later. Same happens if the endometrium was post-receptive, that the window of implantation had already gone. So it's possible to also do use the progesterone for less hours, considering that information. Same happens with the META test. With that test, as we were saying, we are able to diagnose any kind of potential infection. So in the event that we find out that there is a chronic infection, it can be treated. And we can try to remove that infection using probiotics. And at the same time, we are also able to use some probiotics. So the infection would be treated with antibiotics, as I was saying. And we can also try to restore the good environment the uterus should have with probiotics, sometimes oral, vaginal, or both of them, depending on the results of that test. Apart from the endometrium, it's also important, and we're saying also that in the first slide, that it's important to classify and to have the uterus also in the best conditions. So when a patient suffers from failure of implantation or even repeated miscarriages, it's important also to check if there is something in the uterus that can also be affected. So when we talk about the uterus, we can do several tests, non-invasive tests, and also some of one that could be also invasive, with the idea of checking the uterine cavity first, and also the aspect and the shape and size the uterus has. So we normally tend to classify the uterus as normal, or if they had, depending on the malformation the uterus has, we have different classifications and also different results and different solutions. So we recommend doing at least a 3 dimensions ultrasound, which is not, it's like an non-invasive test in which we are just doing a special ultrasound to check that cavity of the endometrium. We are able to know if the cavity is wide enough, if there is something inside that can affect implantation, and we can also see if there is any kind of malformation. And even we are able to see if there is any sign of endometriosis, which in the uterus is called adenomyosis. So with that not invasive test, we are able to know much about the uterus. Same happens with something which is the magnetic resonance. So that magnetic resonance can also give us information in terms of malformation of the uterus, like the thickness of the wall. We can also see if there's any sign of adenomyosis, and it can also help us in having a good, let's say, diagnosis of the uterus. And finally, apart from those non-invasive tests, it's also possible to do a small surgery called hysteroscopy. So that hysteroscopy is, let's say, like a good diagnosed technique, and also like can be like an option to treat certain factors to check first the uterine cavity. So with a small camera, we are going to go inside the uterus, and we are able to see the cavity. We can solve if there is any kind of a septum, a polyp, or so. So depending on what we find, we are able to also try to solve that problem. That, as we were saying before, might have like an important, like would be an important factor for a failure of implantation. So that hysteroscopy is something that can also be performed in order to diagnose and also to treat potential problems in the uterine cavity. So we started like some time ago, like a project here at Clínica Tambre, and which is like related to artificial intelligence with the idea of predicting the best moment for the embryo transfer in terms of receptivity, just doing an ultrasound and using some artificial intelligence device with the idea of having more information first and trying to predict when to embryo transfer. So for the moment, we are still waiting for the results of that project, but I hope to have some news not very far away. So we were saying that an important problem that we normally face in the consultation is what we call that recurrent failure of implantation. So in this slide, you are able to see that picture where you can see like the different steps related to implantation. So the first one is what we call the hatching, which is when the embryo goes out from the capsule, it normally like recovering that embryo, and it's around that embryo. Then the embryo gets closer to the endometrium, and it starts like sticking to the endometrium until it invades the endometrium itself. So there are like many different steps that the embryo has to do before implantation, and same happens with endometrium. So there has to be like a good connection between the endometrium and also the embryo to allow that implantation. So when we are talking about failure of implantation, it was classically defined as the failure to achieve a pregnancy in women younger than 40 years old after having transferred at least 4 good quality embryos. So it was like the classical failure of implantation definition, but nowadays that definition is not, let's say, accepted anymore, because we know that first, we never wait for so long to talk about failure of implantation in a patient. So we don't wait to have 4 embryos transferred with no success. And then we now do like perform many like egg donation treatments, right? And also we perform many times the PGTA, the pre-implantation genetic screening. So it means that we are transferring embryos with really high chances of implantation. So it's not the same transferring a blastocyst embryo that has been tested and we know that it's euplodate, it's healthy in terms of the chromosomes, than transferring, as we did in the past, maybe an embryo on day 3 without doing any extra test. So nowadays, when we transfer 1 or 2 embryos and those embryos do not implant, we start talking about failure of implantation. But at the same time as we defined quite well what the failure of implantation is, we also need to define what is not a failure of implantation. Okay, so when a patient wants to know if they are having a failure of implantation, we also need to find like the context to explain if they are also having that diagnosis or not. So we know that first of all, the implantation pressure also like the success of that implantation depends on the gametes, I mean sperm and eggs, of course on the embryo quality, also depends on the technique that we use to transfer the embryo. So if the embryo transfer was very difficult because of any reason, and maybe we couldn't, I mean, if it wasn't, if there was like some bleeding afterwards or so, it can also affect the success rate. So, and as we were saying before, the idea is that it has to be like an accurate dialogue between the embryo and the endometrium. So there are like many factors that can also affect and can also count on in terms of the result of that embryo transfer. But at the same time, as we defined the implantation failure, what is not considered a implantation failure? So as I was also explaining before, when we are transferring an embryo in a patient older than 40 years old that has not done a PGTA, if that embryo doesn't implant, it doesn't mean that there could be like a problem in the endometrium or a problem in the window of implantation or whatever we want to talk. So the main problem is the embryo, right? So we know that the potential implantation rate with an embryo coming from a patient older than 40 years old, even though the embryo has a good quality, the potential rate of that embryo is not high enough to consider it a failure of implantation. Same happens if we are talking about a patient that has potential hydrosalpingo that has not been treated, or maybe endometriosis, or so that can also decrease the chances of implantation because of the quality of the eggs. As we were saying before, also the quality of the embryos, so we are transferring non-good quality embryos. The main factor of that failure would be the embryos itself. And of course, if we are not having a good endometrial thickness, good endometrial aspect, also one factor that can also count quite a lot is that endometrial development that can also play a role in terms of how frequent would be the implantation in that patient. So what strategies we might have when we are talking about that recurrent failures of implantation related to the endometrial factor? Of course, they could also, we also have like we also had a presentation related to other implantation failure factors, but we are now focused on the endometrial one. So as we were explaining before, I was saying that it's really important to have an exhaustive endometrial uterine assessment. So it's really important to have a good diagnosis. So that diagnosis can be done initially with that 3D scan, also hysteroscopy, magnetic resonance, and also the test that we were explaining before can also give us information that can be quite important to have in order to have the best assessment for that patient. Not all the patients will have let's say a perfect endometrial cavity, perfect endometrium. So we have sometimes to deal with something called the thin endometrium problem. So some patients, even though we give them hormones and so, it's difficult to make that endometrium grow. So we try to adapt the treatment to that, for that patients in order to achieve the best results possible. So one option is in the patient, as we were saying before, is having, let's say, regular periods. We can use a natural cycle to try to take advantage of her natural hormones to prepare the endometrium. Some other cases are like some endometriums are more willing to grow with estradiol and also with substitute hormones. Sometimes we need to use gonadotropins, the same as we use for the treatment and for the IVF round, can also be used to try to make the endometrium grow. And as I said before, some of the treatments sometimes are also needed, such as pentoxifylline, aspirin, vitamin E, sildenafil. So those medications are designed to try to increase the flow of blood to the endometrium and to try to make that endometrium grow like easily possible. And one, let's say, not so brand new treatment that we have been using for some years actually, is what is called the platelet-rich plasma, the PRP. So it has shown like some benefits in patients that might have that failure of implantation, but when it's more like indicated is for patients that have a thin endometrium. So it's so that this new technique is trying to give us like more, let's say, light to that problem called the thin endometrium. We have been using for some years. And it's true that maybe with patients with failure of implantation, it's not so clear if it would be so useful. But we have found that, like for patients affected by that thin endometrium, it can help them to get a better endometrium for the embryo transfer. And of course, it's also trying to improve the results in terms of implantation. So the procedure is pretty easy. We just need a blood sample. So that sample will be used under centrifugation to obtain the serum and to collect the platelets. So with that platelets plasma, we are doing intrauterine infusions, which are not painful, before the embryo transfer. So we normally use 3 infusions per cycle, and we use them like some days before the embryo transfer with the idea of trying to make that potential growth factors that the platelets have to try to have an effect in the endometrium and to make that endometrium grow. So that procedure is painless, it's quite easy. We normally do it in the consultation under ultrasound control to leave the sample in the best place possible, with the idea of increasing the results. In certain, there are like also protocols doing that infusions of PRP under sedation and using sometimes at least using the hysteroscopy technique, but it's like more invasive, but it can also something that can be done. So the results are not clear to be very different, but at least it could be also an option for other patients. So as a conclusion, I would like to highlight that it's really important when we are talking about the uterus and the potential effect that it might have in terms of implantation to have a really accurate diagnosis. So it's important to have as much information about the uterus as possible, with the idea of having also like as many information about the uterine shape, also the aspect of the endometrium, also the cavity of the uterus. So it's important to have a good diagnosis, because having a good diagnosis, we might also be able to treat the potential problems we find in the proper and best way for the patient. So as we were mentioning before, the endometrium is extremely important in fertility treatments. Of course, the embryo is the basis of everything, the basement, and it's important to have the best quality embryo, the most powerful embryo to transfer, that will give us also a higher chance of implantation. But if we are leaving that embryo in let's say, ideal endometrium, not ideal uterus, the chances of that embryo to implant will be quite low. And finally, apart from the endometrial assessment, it's important to have a tailored treatment in patients, especially with thin endometrium and also affected by the failure of implantation. So we need to have sometimes like a multidisciplinary approach, with the idea of giving that patients like the best options for their treatment. And that's all. So thank you so much for your attention. And as usual, I will be happy to answer your questions. I have seen that there have some of them that have been already written in the chat. So, of course, I will be happy to answer your questions, and of course, keep on discussing about that interesting topic.
The information here that we have. My embryo transfer was successful after my fallopian tube removal surgery that was caused by endometriosis. I'm 39, and I am preparing myself again for egg retrieval and embryo transfer. Do you think I should go for this kind of receptivity test you mentioned?
Well, in this case, we know that patient got pregnant before. So we know that at some point endometrium should be in good conditions to allow that pregnancy. So I would suggest that she's 39 years old, and considering that in this scenario, apart from the endometriosis, so like the most important part is the embryo, right? And the quality of it, and also the abnormalities the embryo might have related to age in terms of the chromosomes. So if she's planning to do a PGTA in the embryos, that maybe could be the case. So if that's the case, maybe I would suggest doing maybe the receptivity test, not maybe the receptivity test because it was pregnant before, but at least maybe the endometrial test to check the microbiome. It could be quite interesting to exclude at least that factor. So in the end, it's true that when a patient just has, as we were saying before, one embryo to transfer, we sometimes indicate doing that receptivity test to try to maximize the options. But if you look at the research or so, if she was pregnant before, it wouldn't be completely mandatory, right? It would be just an option.
Okay, right. Thank you so much indeed. And if there's anything else, please let us know. But I think it was a clear answer. There were some questions, very general ones. Would you advise me to take such tests? But of course, this would be really difficult for you to answer because we would need more details for sure. So please remember that. And in that way, it's best to get in touch with the team at Clínica Tambre, and I'm sure they will be able to provide you with more details as long as they have some more information also from you. Okay, so please remember to put all the details if you would like us to take care of that question. And here's the next one. So what if my age is not the only factor? How can I test for endometrial receptivity? This is the next one.
Well, actually, we know that the receptivity of the endometrium doesn't have anything to do with age, right? So being younger or older doesn't mean that you are having more chances of having a receptive endometrium or not. So in the end, it depends directly on the kind of treatment you use and also on the hours of progesterone, right? So in that way, of course, let's say that this patient is, let's say, young. So the option of testing that receptivity, as I said, is doing a mock cycle in which we are using the same protocol that we will be using for the real embryo transfer treatment, with the idea of doing that biopsy, and that biopsy testing that window of implantation if needed, and also the chronic infections that we were saying before.
Okay. Again, very crucial information that you need to remember. Which factors are relevant in the age of 50? I seem to be healthy. Nevertheless, the implantation is not successful. What can I do? And any relevant aspects that you could...
Well, the factors at the age of 15, of course, the main one, one of the main ones, let's say like that, is the chances that a patient has to get pregnant with their own age, with 50 years old, are really, really reduced. So if we are talking about egg donation, which is what almost all patients decide in that group of age, the most important factor, as we were explaining before, is the embryo, right? So when we have done maybe one or two embryo transfers coming from egg donation, as we say before, the age is not playing a role in terms of how likely it would be to get pregnant. So the age might play a role in terms of how that pregnancy will develop and the potential complications that patient is facing because of being 50 or close to 50. So in this case, if the patient is around 50 years old and is doing egg donation, which is what normally happens, if the first embryo transfer hasn't been successful, in that way, as we said, we can also explore the option of testing the uterus in a different way. Sometimes we also indicate certain tests to check the clotting. So in the end, the age is not, when we are talking about certain treatment like egg donation, is not playing a role in terms of letting us know how frequent would be that implantation. But it can have an impact in how that pregnancy will develop in the upcoming months.
Okay, thank you. Sorry about it. I think that we had a bit of a glitch again, but I can hear you, of course.
Yeah.
All right. Next question that I have here: how to improve endometrial receptivity if I had 4 implantation failures? I guess here.
Yeah. So the receptivity endometrium is not possible to be improved. So we can check that receptivity with a test. We were saying before, the ERA test, also the time test. So those tests are designed to give us information in terms of the receptivity. So the way to make the endometrium receptive is with the progesterone. So when a patient takes progesterone, we know that the endometrium changes the aspect, and like something starts changing in terms of the, let's say the endometrium changes in terms of being more receptive for implantation, thanks to the progesterone. So when a patient does and performs this test, and we find that the endometrium wasn't receptive, depending on the result of that, we can adapt into the transfer we were saying. So if the endometrium was fully receptive, for instance, it means that that patient has to add some more hours of progesterone to make the endometrium be receptive, right? So maybe that endometrium, that patient needs, for instance, let's say 12 more hours of progesterone. So we'll add that progesterone, and the embryo transfer will be delayed for some time. The opposite happens when the endometrium needs less hours. So let's say that we found the endometrium post-receptive, which means that by the time we do the biopsy, that window of implantation was already gone. So if that happens, it means that we need to remove hours of progesterone to find that receptivity of the endometrium. So it's true that when we find out that endometrium was post-receptive, sometimes we need to repeat the biopsy to confirm if the window of implantation was as we expected, maybe 1 day in advance or so. So when the endometrium is found as post-receptive, normally we need to repeat the biopsy with less hours of progesterone to find if it was receptive then. But there is no way to say, okay, want to improve my receptivity. We can adapt your receptivity to the moment of the embryo, but there is no way to improve that.
That's the issue. If we could, then it would be so much easier, right? Thank you so much indeed. So not an easy answer, of course, here, not a straight answer as well, I'm afraid. But there, Helen would like to also know a link between endometrial receptivity and recurrent miscarriage. Can these tests reduce miscarriage rates?
Well, which is known is that the endometrial receptivity is not so linked to miscarriage. This is more linked to biochemical pregnancies. And also, which is quite clear that might affect like the miscarriage rate could be more like the infection, that's chronic endometritis. So this test, I mean, if we are talking about the test related to that chronic infections, the idea is that if we diagnose that there is an infection, it can be treated with antibiotics or probiotics if needed to try to restore that environment. And it can also be, it's when we are talking about failure of implantation or even repeated miscarriage, it's very difficult to say that it's just one unique factor. Normally, it's like the combination of factors, but having an infection in the uterus might play a role in terms of miscarriages and also biochemical pregnancies. So not like the receptivity. I mean, if a pregnancy happens, I mean, and then a miscarriage happens, normally it's not related to the receptivity of the endometrium, because if it was, if there was a pregnancy, at some point the endometrium should be in at least optimal conditions to allow that pregnancy, even though the pregnancy didn't develop. So it's more related to the infections normally.
Okay. Again, thank you so much, Helen, for your great question here for sure as well. Thank you. Okay. What's your take? This is the next question. What's your take on the randomized control trial where they compare the standard group, those that do not use ERA test, versus those that transfer under ERA guidance, and it shows that standard group actually has better outcome. There is also another philosophy that each cycle is different, and therefore ERA for the mock cycle might not be applicable to the real transfer cycle.
Yeah, that's a really good question, because it's true that, as I was saying before, that ERA test is controversial. So we don't use it for all patients, because it's true that first, there are like some data suggesting that it might change during the cycle, even though the laboratories we work with normally say that it would be quite stable. Of course, if we follow exactly the same protocol for the embryo transfer for at least 2 years. Of course, if nothing happens, I mean, there is no surgeries or so it can be more or less the same for at least next year. But on the other hand, it's also known that when the ERA test was designed and was started to be used, it was like the research they did was in a small group of patients. So we know that even though we have much more information now, and it's true that a randomized trial was showing like at least no beneficial effects, maybe it's also important to decide what patients are supposed to have some benefits in doing that. So the ERA test, first, is not valid for everyone, first. And second, it's true that we need to look at the results, like, let's say, in not thinking that it would be the only factor, because when we are talking about implantation, it's true that there could be many factors, and doing an ERA test doesn't mean that we are improving the results in a really good, let's say, way, but at least it can help us. And as I said, some patients might get a benefit in doing this test, even though we always explain to them that this is not like the most important test. It could be controversial, but we can also adapt the embryo transfer, even though sometimes, and it's something that we normally do in the daily practice, sometimes, I mean, we prefer to get more focused on other factors, such as the chronic infections and so that have proven before that could have like an important effect on implantation. But I completely agree that there's quite, a controversial issue that some clinics do not offer that test to anybody. And it's also acceptable because of the research we had. But as I said, in that case, we don't say yes for everybody or not to anybody. So the idea is that finally, I think that the good case is that it can be applicable.
True. Okay. Thank you so much. Yeah, we've had some events on that, and ERA test. In the past, I think it was used more often. Nowadays, it's still used. However, as you said, right, this is not ideal, let's say, as well. All right. Thank you so much. And actually, the same patient would like to ask, and just so you can clarify, because we have the ES time known as ERA. Is it known as ERA in the US? And the same is for ES Meta. Is it the same as Emma Alice?
Yeah, so there are like different laboratories that are performing this test. Dina Science is performing the S-Meta and S-Time, and Egenomics is the one who is on charge of ERA, EMA, and Alice, that is called endometrium, when we do the three of them. Yeah.
Yep, exactly. So just to clarify, of course, okay, because it's really important. Some clinics use Emma, Alice, and of course, some other ones can use, as you said, ES time, ES Meta, of course. So this is important. Okay. What's your take? Because there's another part to this question, actually. What's your take on the fact that it's almost impossible to obtain sterile specimen with Emma Alice, since you'd have to go through the cervix, and therefore it might be challenging to interpret the microbiome data?
Well, it's true that, I mean, we need to go through the cervix, that's completely true. But at the same time, we're taking the sample from the uterus, right? So the tissue would be taken from inside, from the uterine cavity. So even though I guess that it would be like maybe difficult to interpret some results, at the same time, as I was saying, we are taking the sample even though we go through the cervix, and it could be some kind of, let's say, of bacteria that could be taken from the cervix. In the end, the tissue, which is the one that they are going to do the culture in, comes from the endometrium. So it's likely that there could be quite a good relationship between what we find in the endometrium and maybe also in the cervix. So in that way, it's true that it could be one good question to say, okay, I'm not sure that I'm getting the results I expect. But at the same time, as I said, even though we need to go through the cervix, I mean, the results are normally quite accurate, and we are able to take the sample from the uterus itself.
Okay. I hope that answers your question. I do believe so. Thank you so much indeed. Hazel would like to ask you, what do you think of DAVE test? And what's your opinion on interlipids IVIG pre-implantation? Any ideas? DAVE test? I'm not familiar with that.
The DAVE test, I don't know exactly.
I can show it to you so you can see that.
Yeah. And in terms of the intralipids and the immunoglobulins, and so that's something that has to be performed under the supervision of immunologists first. So at least here we don't use them in a normal protocol. It depends on the patient, and that patient has to have like a real fear of implantation and has to have the indication of using those immune system treatments to try to increase the results. But as I said, when we are talking about failure of implantation, the first step and the basis of everything is the embryo, right? So then we can add as many things as we want, but the first part and the most important one is the embryo. Then, of course, we can discuss about the immune system or also the uterus, the receptivity, and so. But the most important part is the embryo, and in that way, we do use that intralipids and immunoglobulins when needed. But after having the consultation with the immunologist that works with us, and if he recommends using those treatments, of course, to improve the results, they will be used, and of course, we will be happy of using that.
Okay. Again, thank you so much. I do believe it was useful. Okay. Peter would like to know, so if there is endometriosis just in the ovaries, do you advise to remove them before transfer of PGTA-tested embryo based on egg donor, right?
Yeah. So if there is let's say some cyst on endometriosis, they are not growing. If there is no kind of sign of malignant cyst, and if the patient is not suffering from very heavy pain, there is no indication to remove the cyst at this point, right? Another issue is that normally patients diagnosed with endometriosis might also have adenomyosis, which is kind of endometriosis in the uterus. So if that's the case, of course, we don't treat the ovaries, we treat the uterus, down regulating the patient's hormones with the idea of, if possible, avoiding that potential negative effect of adenomyosis if it happens. Of course, not all adenomyosis has to be treated, because sometimes it's not we know that it shouldn't play a role in that way. But I would say no, in the question of with endometriosis from the ovaries before implantation, if the patient is not having a heavy pain, or if the endometriomas are not growing in the last times.
Okay. Brilliant. Again, thank you so much. There are a few questions left. We will be finishing slowly, but of course, if you have more, we still have a few minutes. So go ahead, type those in. And Peter has asked also here, right, as a follow-up actually, have uterine linings stuck at 5.5 millimeters before transfer? Can it be caused by a fibroid removal operation 12 months ago, or any post-operational endometriosis? Would you recommend 1 month pause after a failed transfer?
Well, in the end, when there is any kind of surgery in the uterus, when we're talking about fibroids or other uterine surgeries, it can also cause a problem in terms of the lining, right? So when the basal layer of the endometrium is damaged for any reason, for maybe a curettage or for operations due to fibroids, it can also cause problem in terms of how the endometrium grows, right? So it's true that in this case, if that patient had a previous surgery related to fibroid, and maybe we don't know if it was just this cycle, and maybe they would be a different way to try to prepare the endometrium. Maybe the doctors will be able to find a different strategy to make the endometrium grow in a different way, at least grow a little bit more. If not, maybe it would be a good option to maybe do an hysteroscopy to see that, the cavity looks fine and there is nothing concerning.
All right. Again, brilliant. Thank you so much for yet another question and answer, of course, here. And let's have a look. One more question, I think. Yeah, sorry. My embryo transfer was successful after fallopian tube removal surgery, but unfortunately lost my pregnancy at second trimester due to ultimately cervix dilation. I had a DNC and hysteroscopy followed by the loss to clean uterus. I have no euploids left, preparing again for egg retrieval and transfer. 39, and I have stage 4 endometriosis. Do you think I should go ahead with receptivity test before any other transfers?
In this case, I would say not receptivity 1, okay, because that patient got pregnant, so the receptivity should be fine. And the fact of losing the pregnancy was not related to the embryo itself, was not related to anything. It was just because of the dilation the cervix had. So maybe it could be a good option, because sometimes when the cervix starts opening, it could be because of infection. So maybe it could be a good option to do just a biopsy to check the endometrium in terms of that infections and microbiome. And if everything is good enough, I wouldn't suggest doing that receptivity, because in this patient, I think it's not indicated because the person got pregnant.
Right. Okay. Thank you so much. That's another interesting question, I guess, here. So now I'm looking possibly at our final questions. So if you have more, go ahead, type those in. If not, we will be finishing, of course. But if you have any more questions, you can definitely get in touch with the team at Clínica Tambre directly as well. And let's have a look. Okay. The question is, can you explain how receptivity is more related to biochemical pregnancy? I was told that if there is plus HCG, positive HCG beta, sorry, I lost it somehow. Sorry. Then the implantation has occurred, and therefore the loss of the biochemical pregnancy is not from implantation failure. Is this accurate? In other words, if it is implantation failure, then there shouldn't have been any HCG positive beta. Is that accurate?
Yeah, so it's true that when there is a biochemical pregnancy, it means first that at some point there has been some kind of implantation. So sometimes the embryo doesn't develop because of the embryo itself, but we know that that receptivity can also play a role, because sometimes the window of implantation, which is like a window, is supposed to be that opens and closes. It's related to the genetic expression on the endometrium. So sometimes that receptivity, maybe when the embryo was implanted, was in the best conditions, and it can also help in not helping, let's say, the embryo develop properly and the pregnancy keep on developing, right? So it's true that when a biochemical pregnancy happens, there could be many different factors, but it seems that at some point that receptivity test can also help us. And having that implantation doesn't mean that the pregnancy will develop properly. So it's just a matter of, like, at least we know that the embryo attached to the uterus, but there have to be like many other steps to make that pregnancy develop. So I agree that the fact of having a positive pregnancy test means that the implantation has happened. But as I said, sometimes the biochemical pregnancy can be related. Apart from that, let's say, problem in the window of implantation, they can also be quite related to the infections in the uterus. And it has been quite shown in the latest research, and that's the reason why sometimes, I mean, if the implantation happened at some point, sometimes we just recommend doing that microbiome test to make sure there is nothing concerning in the uterus.
Okay. All right. I do believe it was useful for you again. And one more question in the meantime we did receive here. The question is on endometritis. What's your definition of endometritis? I heard different ones, where one asked for 10 plasma cells and the other clinic believes that if it is more than 3, then it is endometritis. Any thoughts on that?
So the endometritis is defined as the chronic infection of the uterus. I mean, that's like the definition, but it's true that when we are talking about the plasmatic cells, which is called CD138 positive cells, so it depends on the laboratory. So depending on the laboratory, they have like the limits to say, okay, this is normal and this is upper the limit. Apart from that, it's also really recommended to also do a culture of the endometrium. So it's important to know if there is a bacteria which is causing that infection, and if there is a bacteria, also to have like the antibiogram to know exactly what antibiotic we might need to use. So the definition is not so clear, because in the end it depends on the laboratory that clinic works with. Depending on that, they happens to many other like parameters they find, and they put a limit in which they say, okay, this is normal and this is upper the limit. Same happens, for instance, with the natural killer cells. Depending on the amount we find, we can classify like a normal endometrium, or sometimes that an increased NK cells. So in that way, as I said, it depends on the laboratory and the limits that the laboratory wants to put.
Okay, thank you so much. Yeah, this is very important again. So thank you for your detailed question. I think it was useful as well. So the more questions you have, the more happy we are for sure. Lots of questions today. So thanks a lot for your for being with us here. And Dr. Marbán, thank you so much for your time. I think it was very, very useful. Remember, it's been recorded as well. So if you had to leave at any point, you will have a chance to rewatch this. All right, so I think that will be it for today. Before we finish, anything else you wish to add? Thank you so much. Glad to see that the presentation was awesome. We are definitely happy to be able to help. For sure.
Yeah, as always, I would just want to say thank you for the opportunity of sharing some information about our daily practice with patients and so I'm always happy of being here, and I'm happy of having the chance of answering questions and also presenting some important information and important issues that we sometimes find in the consultation. So it's always a pleasure for me to be here.
Definitely. So thank you so much for today. Remember, we will be back with some more events, and I'm sure Dr. Marbán will be back as well. So stay tuned. We will be back actually also tomorrow. So you can go to myivfnss.com website and you will find all upcoming events right there. Thank you so much for today. And remember, if there's any other things that you wish to ask, you can definitely get in touch with Dr. Marbán, her team at Clínica Tambre. And I am sure they will be able to help you even more. So thank you so much. Take care, everyone, and have a lovely evening. See you soon. Bye.
Bye.